Here's Bob, and we're going to introduce our prostate expert. Thank you, sir.
For those of you who think you wandered into the Maritime Center, this is actually the correct lecture. This is on prostate disease. And thank you all. I should say good evening, wise men. We see a lot of you. Just wanted to go over with you the format. I'm going to be speaking about a thing called benign prostate hyperplasia. And I'll be speaking about 20 minutes, and then we're going to bring up Dr. John Graham, who's a urological oncologist, and he's going to talk about prostate cancer. I did want to give you a little of his background, because he's new to the group. Basically, John went to Temple University Medical School and graduated with his MD, then went to the State University of New York and became a surgical resident, stayed there for his urological residency, went to USC Institute of Urology to do a fellowship in robotic surgery, and finally Weill Cornell, where he was an attending and a assistant professor. He now is working as an attending urologist at the Tallwood Urology and Kidney Institute. He has had multiple publications, multiple presentations, and I think you're going to really be happy. So right now, though, you've got me, and I'm going to talk about benign prostate hyperplasia. First, let me just get the concept of what hyperplasia means. It's important. Hyperplasia basically means that there are multiple cells. Cells have divided frequently, and you've just got an increase in number of cells. They're not cancer, they're benign, but because there are many of them, they cause enlargement, and that enlargement has implications. A lot of you may have heard the term benign prostate hypertrophy. Hypertrophy means the cells are getting bigger. That's not what happens, so that's kind of an arcane expression. We shouldn't use it. Benign prostate hyperplasia, or I'm going to use it because I can't say hyperplasia that many times, BPH. Okay, so we're going to talk about BPH. But first we're going to talk about the prostate. Most of the audience has one, some of the audience does not, but most of us do have one if we're male. And basically, what is the prostate? Where is it? What does it even do? It's actually a small gland, and they said this would work. Let's see if it does. No, it does not. So it's a small gland just below the bladder. You can see the bladder obviously outlined, and there's the urethra. The urethra is the tube that leads from the bladder. And that's how we urinate. We go out the urethra, out the penis, and urine comes. Surrounding that, at the very base of the bladder, is a simple gland. It's the size of a walnut. It causes a lot of problems for a size of a walnut, but it's quite small. And that's the prostate. And why is it there? Well, it turns out the prostate is there to make secretions, and those secretions nourish sperm. So basically, the prostate gland is almost a fertility gland to help sperm move and be adequately nourished so that they survive. And not surprisingly, because of that, for the first 10, 12, 13 years of a man's life, it's a pretty dormant gland. Doesn't do much, it's quite small, because you don't really need it. But when adolescence hits and testosterone begins to surge, that's when the gland begins to grow. And basically testosterone and a metabolite of testosterone called dihydrotestosterone, and it's important to know that because that's one of the targets of treatment of this problem. Dihydrotestosterone is basically fertilizer for the prostate. It's like you fertilize the prostate, it starts to grow. And it grows throughout your life. As it grows, it's doing things, making prostatic secretions, but at a certain point, it'll begin to grow. And as if you notice, the prostate is surrounding the urethra. It's around it. So when it grows, it not only grows out, and we can feel it, but it grows in and can almost strangle the urethra, so it's harder and harder to urinate. It's a little bit like stepping on a garden hose. And basically, the pressure is backing up, and it's hard to urinate, and you have to strain. That is what causes prostate problems. Now, the prostate itself is not totally uniform. And I mentioned this. This is a picture of the prostate. You can see that big red tube. That's the urethra. There are different zones in the prostate. You don't have to know them. The only thing that's interesting about that is that one of the zones, called the transitional zone, which you can see is number C, is not very large, but it surrounds the urethra. So even if it grows a little bit, it can cause some symptoms by tightening around the urethra. We may not feel it when it's growing because it's very inside the prostate. It's not on the outside. The peripheral zone, which is D, that's where prostate cancers often form. So sometimes, because the transitional zone grows but isn't felt, you can get a disconnect between an exam, which might not feel a big prostate, and yet the person may have very severe prostate symptoms of benign prostate hyperplasia. So it's a worthwhile thing to know, just clinically, you don't always feel a big prostate when a person has symptoms. So this is kind of a simple picture. There's your prostate gland again. You can see the usual prostate, that tube down the middle, very clear. That's an easy garden hose. You can urinate through that. Fast forward, you're now 70, 80 years old. Your prostate has enlarged over 60 years since puberty, and you can see how it's beginning to tighten on the urethra. That makes it difficult to urinate. The other thing is it's also growing up into the bladder. The top of that is the bladder, and that irritates certain nerves in the bladder. So you get two types of symptoms with benign prostate hyperplasia. One is irritative symptoms of the bladder, where you have to go a lot. You have an urgency, you have frequency, you have nocturia, which means you wake up in the middle of the night, or if you're like me, you don't judge your distances in driving by how many hours, but how many pit stops. You've just got to go a lot. That's irritative symptoms of the prostate. The other type of symptom, not surprisingly, is you've got this tube that's now being grabbed by the prostate, and that causes obstructive symptoms. And the obstructive symptoms happen because you can't get through the prostate. You just can't push it through. So you have symptoms of hesitancy. You got to strain. When you urinate, the man doesn't feel like he's completely evacuated. He dribbles after he's finished. Those are obstructive symptoms. And I only mention this because they are treated slightly differently. There are irritative symptoms where you can't store the urine, you just got to go a lot. And there are obstructive symptoms where you can't empty the bladder very well. Slow straining, slow stream. You used to pee like a racehorse, they say. Now you can't. That's basically what happens. And this is kind of a summary of that. The important thing is we call this collectively LUTS, which is basically lower urinary tract syndrome. People refer, if you read about it, they always refer to LUTS. LUTS really means two things: irritative symptoms and obstructive symptoms. Now, the obstructive symptoms are interesting for another reason. They are really made up of two factors. The prostate itself is just a big organ. It's just pushing on the urethra, and it narrows it. That's a static kind of thing. If you want to treat that or shrink the prostate, you can do it. We have medicines to do it. We'll talk about it. It takes quite a while. That takes months. Whereas there's also a dynamic component to that obstruction, which are basically smooth muscles inside, around the urethra, in the prostate. It's basically a prostate smooth muscle. Muscle can contract and relax. And we can treat that, and that can happen to give results very quickly. We have drugs called alpha blockers that relax the muscle, and the tube opens up a little bit. So you can get a quick result from those, and a slower but equally important result from shrinking the prostate. And that's the basic concept of how we manage prostate disease. So how common is this problem? This is a really common problem. 30% of all men will eventually have prostate symptoms in their lifetime. They'll be symptomatic from this disease. And if you jump back to the bottom, if you look at autopsy studies, which is not really totally fair, 90% of men who live to 90 will have benign prostate hyperplasia, at least in their organ. But 30%, and it amounts to 40 million men. 40 million men will have prostate symptoms. It's a huge problem in the United States, and it used to unfortunately only be treated. When I started practice, we basically had surgery. That was it. Now we have other medications, and actually surgery is pretty infrequently done. So if a patient comes to me, how do I know, or how do I quantitate his symptoms? How uncomfortable are you? And this is the International Prostate Symptom Score. Basically, it's just a list of the very things we talked about: incomplete emptying, frequency, intermittency, urgency, the very symptoms, irritative symptoms and obstructive symptoms. And they just ask how often does it occur, and they give it a point. And by giving the score, you just sum up the score, you get a feeling for how many symptoms they have, how bothered they are by this. This is one of the ways we can track whether our medications or things are working. We try to objectify it. The bottom line is probably the most important, the quality of life. And that's not an objective. That's simply asking the man, how much is this impacting on your quality of life? And the reason that's critically important is because this is not a disease like the next one we're going to talk about. This can't kill you. This is just unpleasant. This impacts on your sleep, it impacts on your quality of life, irritation, sometimes incontinence, but basically it's just an unpleasant disease. If you don't treat it, you'll just go through life with an unpleasant problem. Don't have to treat it. How much it bothers you should really define how it's treated. And that's an important concept for this particular problem. We're treating a symptom, not something that's life-threatening. So why do we care about it? Really, basically because it interferes with life's routine. These other problems are when the symptom can really get bad. And if it really gets bad, it can cause real obstruction. And then basically the bladder can't empty. If the bladder can't empty, you can get acute retention, which means the bladder's just not emptying at all. You can't urinate. I don't know if it's happened to anyone here, but I've seen many people, you have to catheterize them, you have to do something. Basically, the pressure of the fluid backs up, and it can damage the kidneys. It goes from the bladder up the tubes to the kidney, the pressure builds up, kidney stops making urine, and you basically don't have functioning kidneys. That goes on long enough, they're permanently damaged. But that's a rarity. I want to emphasize that. The other thing that can happen if you have urine that can't be left out, you have always a constant pool of urine in your bladder, and that's kind of like food for bacteria. So bacteria begin to grow when you have recurring infections. And the other thing that can happen is that the various things, the chemicals in the urine, like calcium, phosphate, they can start to crystallize out, oxalate, and you can get bladder stones, which can cause bleeding, irritation, ulceration. All those three complications really are only in very severe prostate enlargement. Most people, it's just how much it bothers you. And again, this really is not worth asking because I just mentioned it because it's always in every article, but risk factors are kind of ridiculous because the only real risk factor is you're a male and you live long enough. As I said, 90% have it by the time they're 80 years old, at least histologically by lab, and then 30% will have it. So the other factors really they're not modifiable, you really can't change it. One of the things that is really critical from the internist perspective and from the urologist perspective, although I usually see these people first, is that not everything that causes you to urinate slowly or irritates you to go to the bathroom frequently is benign prostate hyperplasia. And that's important because the other things are important. BPH is much more common, but one of the critical jobs when somebody comes to you with LUTS, lower urinary tract symptoms, is make sure they don't have one of these. And if you think about it, you have the bladder that's constricting and pushing out a tube. Well, if anything decreases the bladder's ability to squeeze, some kind of neurological disease, that can cause symptoms that look like you have BPH. If you have a urinary infection or a prostate infection, it's irritative. It looks like BPH. Prostate cancer, when it grows, can grow into the bladder, or it can get big enough to obstruct the tube. Again, looks like BPH. And there are an enormous number of medications, very common ones, antihistamines. They relax the bladder, can't contract. Opioids, certain antidepressants, even pseudoephedrine, which is Sudafed. You take Sudafed, it actually works on the smooth muscle, constricts the smooth muscle, and it looks like you're obstructed. So when you see the person, the major job for me, other than treating the symptom, is to make sure I'm not missing something important. It's not hard to do. You can ask them questions about neurological problems. You ask them what medications. You can think about prostate cancer. You can check for urinary infections, but very critical you do that. So how do we make a diagnosis? One of you walks into the office, Bob, I'm urinating a lot at night, go a lot, my stream is weak. Well, the symptoms sound certainly suggestive, a little irritative, a little obstructive. That really makes me think might be BPH. That's important. My first goal, however, is to rule out the other causes. I ask the right questions, hopefully, about medication, history, infection. I do a digital rectal exam, something nobody likes to have, very important exam. Not to find BPH as much, because remember, the transitional zone may be important in obstructing you, and yet you may not be so big on the exam. It's important, but what I'm really looking for is there tenderness? BPH is not tender, so that would suggest an infection. Is there a nodule, or is there something that feels like a stone? Prostate tissue is kind of firm, but if it feels like your cheek, a cheekbone, and it's really firm, you think about prostate cancer. If I do a rectal exam and the man doesn't complain at all, or it's very easy for me to enter, or he doesn't feel it very well, that suggests some kind of neurological problem. So the rectal exam gives me a wealth of information about what it isn't, and that it's probably BPH. Then I look at the urine analysis, look at the urine, look for infection, should be culture negative, look for blood, bladder cancer, bladder stones, prostate may have blood in the urine, but BPH won't. The urine should look relatively pristine. And that's basically all I really need to do. If I'm worried about the kidney, I can do a blood test for kidney. A lot of people will do a PSA, even though that's all, really you're looking for prostate cancer, not looking for BPH. The other value of the PSA, it gives you a gauge along with your exam how big the prostate is. There's a number of 1.5, which is kind of correlates with the prostate size of about 30 grams. And the reason that's important is because some of the medications that shrink the prostate that we'll talk about really aren't very effective if you don't have at least a 30-gram prostate. If it's not a big prostate, you're not got a lot of bang for your buck. So that's useful. The rest of these tests, as a general rule, you don't have to do. You could do a post-void residual, which means you empty your bladder and we see how much urine is left. The urologists have an ultrasound in their office. Most internists don't, but certainly reasonable to do. You can actually even measure how good your stream is. I can say, go in, time yourself, and there's a little flow meter, and we can actually, you urinate a certain amount of urine per second. I get a feeling for your symptoms. But again, remember, it's really how much it's bothering you, not how much it bothers the uroflow meter. So if you're happy with the speed you urinate, I'm gonna leave you alone. If it's really bothering you, I need to treat you. And the treatment is based mostly on how much it bothers you. Other diseases might be factored in. If you have certain heart diseases or blood pressure problems, I might choose one medication over the other. If your illness is really severe, I might think about moving you to double therapy right out of the box. And as I mentioned, the size of the prostate is relevant because you wouldn't use a medicine to shrink the prostate that isn't terribly large. And once in a blue moon, when it's really large, you'll again combine drugs, or you might just send them right to the urologist. But these are very simple factors that you can make. You don't need to be a brain trust to figure out that a person's really uncomfortable or they're not bothered that much. Every article on prostate disease says, first start with lifestyle. If they're bothered, now lifestyle, there really isn't a great therapy for lifestyle. If you wake up a lot at night to urinate, again, you don't have to be Einstein to figure out, don't drink a lot before you go to bed. Makes sense. If you're going on a long trip, don't drink 3 jugs of water. But that's really what we have. They say caffeine and alcohol are a little irritating to the prostate, so it might magnify the symptom. That's reasonable. Don't do that. Time voiding simply says you know that you have a certain frequency to go. You can work rather than waiting till you feel urgent, or whether waiting till you really have to go. You just say, well, about every 2 hours I need to urinate. So make that part of your schedule, factor that in. Those are easy things to do. You can try Kegel exercises and floor exercises, much more effective for women and for incontinence than it is for the prostate. Which really means, how do we treat it? Well, again, it gets back to simply that simple physiology that I discussed. You have a bladder that squeezes. So if it squeezes and it's very irritated, it's going to make you feel like you have to urinate. You could use something to relax the bladder. And there are drugs that are called anticholinergics and beta-3 agonists. You can have that smooth muscle around the tube, grabbing the tube. That you can relax with 2 things. One is a drug called an alpha blocker, which probably some of you take. Tamsulosin is probably the best known, Flomax. But if you relax this smooth muscle, you can urinate better because you open up the tube. One thing that surprises people is that a group of these drugs called PDE5 inhibitors, most well-known is Cialis. We think of that as an erectile drug. It's good for erectile dysfunction. Well, it actually works very much. It relaxes blood vessels in the penis, and they swell up, and that's how you get an erection. Well, if it relaxes smooth muscle cells in the prostate, it relaxes the prostate, and you can urinate better. So you can essentially kill two birds with one stone with PDE5 inhibitors. These are the treatments that we have. And then the last thing, if it's a big prostate, you have to be very patient with this, but you can shrink that prostate over time, because if you were listening a few minutes ago, testosterone and dihydrotestosterone are fertilizer for the prostate. What if we can prevent dihydrotestosterone from being made from testosterone? We have medications called 5-alpha reductase inhibitors. They block the transition from testosterone to dihydrotestosterone. Over time, the prostate shrinks. So this is how we treat prostate hyperplasia in 2025. None of these were available when I started practice, and they all work very well. And honestly, sending a patient now for prostate surgery is pretty infrequent. I do want to emphasize supplements, which you will see advertised on YouTube like crazy. Very little data for this. Saw palmetto has actually been well studied. It doesn't work. There were 32 randomized trials. It's a disappointment. Would have been nice. The others, like beta-sitosterol and PGM africanum, they may actually have some benefit. Very small, but they have some. We don't know their safety data. We don't know their long-term effects. The other drugs that we do have, very effective, very safe for the most part. We know what we're dealing. We know their drug interactions. I would not recommend, just because you can buy it in a health food store, using it. Plus, I've talked about this before, you never quite know what's in those supplements, and that's been shown. So this is kind of a pictorial, obviously, of two of the most important treatments. The 5-alpha reductase, that's the one that takes testosterone to dihydrotestosterone. It prevents that. It blocks that. So it takes this big prostate and can shrink it back down. The other one is an alpha blocker, and that's because the nerves that feed the smooth muscles are they're like adrenaline. They're called noradrenaline, norepinephrine, and they work on certain receptors called alpha receptors. They tighten. If you can block that, you can relax the prostate smooth muscle, relax and open up the tube. So those are your two major treatments. This is a little more complicated. I don't have the pointer, but I do want to emphasize again, you have the alpha blockers in the middle. You have the 5-alpha reductase inhibitors blocking the testosterone. Both are very effective and basically do most of the lion's share of treatment. If the person has an erectile problem and you want to treat two problems at once, you can use the phosphodiesterase blocker, PDE5, like Cialis, and that basically will relax smooth muscle, and that helps treatment. And then finally, if the bladder is the major irritant, you can use antimuscarinic blockers and beta-3 agonists. 4 different categories of treatment, and they all work. And what we often do is combine them. We would often take a person with a big prostate and start them on an alpha blocker, because that works quickly on the smooth muscle. That works in a few days. But if they have a large prostate, we can also start them, for instance, on a 5-alpha reductase inhibitor. That takes 6 months. No one wants to walk around with symptoms, but together, in a year or two, they're actually better than either one alone. And you can really reduce the risk of surgery. If a person has an erectile problem, try a PDE5. Combine the two. Give them benefit of both. Combining a PDE5 and an alpha blocker isn't done very frequently, even though people ask me that all the time. Can I just take the two? They both work on smooth muscle, so they tend to be redundant. You don't get that much bang for your buck combining the two, and you will lower blood pressure. So occasionally you will do the two, but you have to do it cautiously, and that's the treatment there. This is just a list of the common alpha blockers. I only mention it because, as a general rule, the top 4 are not selective. They're not as precise. They have more side effects. I would say if you're going to take an alpha blocker, which is the main treatment, you should use tamsulosin, which is Flomax, great name, or soladocin, which is a better name, Rapaflo. 2 great names. And honestly, they're good drugs, and they're very safe. They do have minor side effects, occasionally lowering blood pressure. We can talk about, fine-tune that. They do cause a fascinating thing in the eye. If you have cataract surgery, they cause a thing called floppy iris syndrome. And anything called floppy iris syndrome can't be good. But it's not a terrible thing. Your doctor, your ophthalmologist has to know you're taking the medicine to prevent it. They also cause an interesting thing called retrograde ejaculation. And what that means, let me see if I can show you. If you open up the tube enough and a man ejaculates, the sperm has a choice. You can go out the penis or the path of least resistance now back into the bladder. It goes either way. Well, sometimes that can be a problem. Men will call you up in the middle of the night, something's gone horribly wrong with this medication. You better tell them that before you give it to them, because it's not a problem. Feeling is, of an orgasm feels good, but you certainly may interfere with fertility. And more importantly, it's just a symptom that they should know, because it seems very frightening. But if you mention it to them, most men will tolerate it. Some men will say, I don't like this. Important side effect. This is just to show you that the testosterone going to dihydrotestosterone, that's the basic fertilizer for the prostate, is blocked by drugs like finasteride, which goes under the name Proscar, dutasteride, a drug called Avodart. They work very slowly, but they're very effective, and they're surprisingly safe. They have a few side effects, but again, you can talk about that with the physician. It complements the alpha blocker, so they both work through different mechanisms. Now, this is just a busy slide. The only reason I mention it is because this is the list of things we can do. Alpha, PDE5s, 5-alphas, anticholinergics, beta-3 should be on that, and combination therapy. That's a lot of treatment from nothing 30, 40 years ago. And what if nothing works? What if you've done it all and this poor man just can't pee, can't urinate? It's really a truly quality of life issue. It is extremely distressing. Well, those people, we have surgery. And that's where I would call Dr. Graham and say, fix this person, please. And what I love about the surgery of prostates, I just love the acronyms. TUNA, TULIP, TERP, wonderful acronyms. But basically, they all are basically procedures where you go through the urethra, you pass a scope into the urethra, you reach the level of the prostate, and you do something to open up the tubing. It's basically, I don't want to, kind of reduce it to rotor-rootering, but it's a little bit like that. and basically, these stand for the different things that do it. You can resect it with almost like a knife, like a TURP, transurethral resecting. You can do a TUMP, which is microwaving it. You can use TULIP, down there, which is basically laser. You can just make a small incision and cut it. Or you can try a needle ablation. You take like electrocautery. They all basically are doing the same thing. The reason we distinguish them is they have slightly different invasiveness. Some of them can be done only as an inpatient. Some of them are a little easier you can do as an outpatient. Some of them have a higher risk of retrograde ejaculation or occasionally incontinence. Some of them have lower, and some of them have, excuse me, a higher incidence of needing another surgery. So what I listed here is the risk of another surgery. I thought that was often the most important. For a TERP, only 7%. For the microwave, 20%. For the incision, 13%. For the urethral needle, the kind of cautery, 12%. The laser, 7%. And one other technique, but before I do that, I just want to show you what happens. You pass the scope up the urethra into the prostate. They clean it out. And you hope that it goes from that tight to that open. And this is kind of more graphic picture, but you can see how you've really opened that tissue. The one on the left is normal. This is the squeezing, and this is after you've basically resected it. This is another device. Again, this is the electrical one with the needles. No different from laser, no different from wrist. They all are doing the same basic concept. Once you understand the concept, you talk with the urologist and you decide which one is best for you based on side effects, based on likelihood you may need another surgery, how well you tolerate it, whether you want to be inpatient, outpatient. Those are all decisions you can make. Some of them require a larger prostate or only can be done with a smaller prostate. Again, those are all decisions that can be discussed. This one I like just because I think it's a cool idea. Actually has a reasonable high rate of recurrence. You may need another procedure. This is nothing is removed. They basically are putting in, they pass the scope, and they're basically almost pinning out the prostate. They're just telling these clips, and they're clipping them so they pull the prostate apart. It's called a urolift. It can be done non-invasively, but it does have about a 15% recurrent risk of need. Doesn't have any major side effects, and again, it's not non-invasive. So all these work. They have slightly differences, and this is kind of a crazy summary slide. I'm going to be testing you after. Don't have to even look at it, but just look at the side effects: proportion requiring surgical retreatment, incontinence, erectile dysfunction, retrograde ejaculation. They all differ. And you and the urologist can make the decision which one of these problems you're willing to. Maybe retrograde ejaculation isn't a problem, but the idea of going through a procedure twice is horrendous. You might choose one procedure over the other. These are kind of the numbers. But again, this is for you and the urologist. So, in summary, this is how at least an internist thinks about BPH. And I think it's the way urologists do, but John can correct me. Basically, you walk in with LUTS, lower urinary tract symptoms. My job, I'm already thinking this is probably BPH. You're a 75-year-old man, you're having little symptoms of irritation, nocturia, you're waking up, you can't pass a bathroom without stopping. Very typical. But I've got to rule out the other diseases. So by asking you the right questions, looking at the urine, looking at the blood, doing a digital rectal exam, maybe a PSA, maybe a uroflow, I get a feeling, oh, there's something worrisome about this. This doesn't fit. He's got blood in his urine. He's having recurring infections. I did the rectal, I feel the hard, stony nodule. That person I'm going to refer. They make up a very small percentage of who I see, but those are the people I'm going to refer. If, however, by default almost, and I feel a large prostate, then I've decided they have BPH. I use that little screening test, the IPSS, International Prostate Symptom Score. I get a feel for how much this bothers you. And then at the bottom, I ask you the most important questions, which is this mild, moderate, terrible? I can't live another day like this. I get a feeling for how much you are bothered, and I make a decision about treatment. Most of the time, I mention lifestyle. Most men have tried it already. And then I try a single drug if it's not a huge prostate, and I usually start with an alpha blocker. But if they have erectile dysfunction, I'll start with a PDE5 like Cialis. I won't combine the two. If they have a lot of symptoms and they really can't wait, I can't just use an alpha reductase. It takes 6 months to shrink the prostate. So I might start an alpha blocker and an alpha reductase, and very effective in reducing need for surgery. On occasion, if after I've done everything, even their flow's better, but they still feel a lot of irritation, I might treat one of those bladder relaxants. And if all that fails, which is becoming increasingly rare, I will send them to surgery. And that's basically the treatment. This is a very common problem. Again, 30% of men, not life-threatening, but really life-limiting. The treatment is based on how bad it bothers you. We make sure there are no other diseases, and only a small percentage of people will go on to surgery, but we have really good, better medical therapies, and again, less invasive surgical therapies for this disease. So with that, I want to pass the microphone over to Dr. Graham, and thank you for listening. There you go, John.
Okay. And I think, yeah. Okay, very good. So first of all, I want to say thank you to Mr. Wilk and Dr. Altbaum and the Westport Lecture Series for inviting me here today to give a talk on prostate cancer. My wife and I actually just moved to the area about 2 years ago. As Dr. Altbaum properly said, we had been in New York City for about 5 years prior when I was with Weill Cornell covering a practice in Lower Manhattan, Brooklyn. So we're very fortunate to be here and starting to be a part of the community. And I want to apologize in advance. It is November, so much to the disappointment of my wife, you'll have to look at my mustache tonight, but I'm quite proud in my ability to actually grow one. So who am I? My disclosures, I should say at the beginning, I have done some work with Medtronic, working on a new robotic surgery platform, but otherwise nothing necessarily to to disclose. So what are we talking about today? So this is the conversation I have with patients every single day when I'm in the clinic, multiple times a day, but admittedly within pieces. So today we're gonna kind of try to digest it all. My goal is to make it bite-size, but realizing that we'll have to take several bites in order to do it. So we're gonna talk about prostate cancer, and then I want to transition from that into how we reach the diagnosis, work up the diagnosis of prostate cancer, and what's involved in that. I'm going to talk about some emerging technologies and how we stage prostate cancer, identifying local or metastatic disease, and then touching on the treatment of prostate cancer and what some of the newer technologies that we're able to offer. So not to be too redundant to what Dr. Altbaum had said, the prostate is that gland that sits right below the bladder, and the tube you urinate out of, as he says, runs right through the middle of it. But what does it do? I mean, it's a reproductive organ, so it makes seminal fluid. It makes a hospitable environment for the sperm to exist and to function. The vagina, the uterus, this is an inhospitable environment, and the fluid created by the prostate tries to select the strong swimmer for reproductive reasons. As we talked about, benign prostatic hyperplasia is an overgrowth of this area, but in general, a prostate normal size is about 20 to 30 grams, the size of a walnut. Now, with respect to cancer, we talked about BPH locations, but where does cancer typically form? So as you see here, the yellow area, or that back side of the prostate, the peripheral zone, is where the majority of prostate cancers form, right? So before we had blood testing, your PSA, how did we identify men that may or may not have prostate cancer? Was the digital rectal exam, literally feeling for abnormalities in this zone on the back side of the prostate. In addition to that, there's the transition zone where prostate cancer can be present, estimated about 20% of the time. So when we were doing our biopsies prior, we were just sampling these areas where prostate cancer was known to typically exist. So, prostate cancer itself, some of the facts. It's the #1 diagnosed solid organ cancer in men. 1 in 8 men will be diagnosed. It is a cancer of older men. As we age, our risk increases. Very rare to see men under the age of 40 be diagnosed with prostate cancer, but men with Black ancestry are going to have a higher risk of getting prostate cancer, are going to have a higher risk of getting prostate cancer at a younger age, or getting a more aggressive form of prostate cancer. So we consider some of these risk factors when we talk about how and when and who to screen. Although being the #1 diagnosed cancer, solid organ cancer in men, depending on the year and the statistics, it's about the second or third leading cause of cancer death. So it really highlights the need for early detection, and that affords you the ability for an array of different options as far as the management. Trailing lung. There's a lot of different forms of prostate cancer, but the overwhelming majority is an adenocarcinoma. It simply just means that it's a gland cancer. So what are some of the risk factors? As we already said, age. As you get older, your risk of prostate cancer increases. As we said before, ethnicity is something when we do our history and physicals, seeing patients in the office, we're trying to tease out some of these details. So men with Black ancestry, as we said before, have a higher risk of getting prostate cancer, getting it at a young age, and getting a more aggressive form. Individuals with a family history of a first-degree relative, so your dad, brothers, etc., who have prostate cancer, but also the women in your lives, right? The cancers that somewhat are similar to prostate cancer, so your ovarians, uterines, endometrials, breast tissue, and also other adenocarcinomas like lung or pancreatic. So knowing if there's other individuals in the family who have cancer may clue us in on an interest in workup and how it could affect the age. Probably no surprise to anybody, smoking is bad, right? So smoking can increase your risk of prostate cancer. Diet, so diets that are high in excess calories, right? Processed foods, a lot of meats and cheeses and sugars, these are gonna have been shown to increase your risk of prostate cancer. So when patients ask me, well, what can I do? What are some of the modifiable things I can do to lower my risk of prostate cancer? It would simply be the opposite of this, right? Don't smoke and eat healthier, right? These aren't shocking revelations because you can't largely change a lot of the other things on the left-hand side of the slide. Okay, so the work of prostate cancer, everybody has, well, a lot of the individuals in the room have had a PSA that has been drawn, whether you're aware or not, typically by your primary care doctor. And what is it? It's a blood test. It is a screening test. So for women, mammograms are a screening test for breast cancer, right? There is something there, there isn't something there. For men, the blood test is the screening test we use for prostate cancer. What is the PSA, though? It's a protein. It has to do with the liquefaction of seminal fluid, again, playing a role in its reproduction, but we can measure it. So there are certain things that when we measure that value, that cause it to be elevated. So, topic of discussion today, sure, cancer, right, of course. But there are other things that can cause your PSA to be elevated. So, as Dr. Altbaum touched upon, just having a big prostate. It's a big factory, it's a big thing, it can make a big PSA. So there is some ratios we do consider when we understand the size of your prostate and what your PSA value is. Things like infections, right? We want to know if you have a urinary tract infection, causes an area of inflammation, can drive the value up. If we're doing things, putting catheters in your penis to drain urine out, cameras into your bladder for whatever reason, other workups, things that we love to do as urologists, can transiently elevate your PSA in those values. We always encourage patients, right? You go to your Quest lab or somewhere to get your blood drawn and you're fasting. Well, we would also encourage you to fast from ejaculating. So ejaculating within a couple days of the test can transiently elevate your PSA. So we do try to take that into context. Okay, so as Dr. Altbaum talked about, there are medicines that men are on to help them urinate, right? And we want to know that. We want to suss that out when we're doing our history and physical. Being on one of these medications, finasteride, dutasteride, also known as Proscar or Avodart, can artificially lower your PSA. So driving your PSA down is not something that we do, right? So if you think about my blood sugar, my cholesterol, my blood pressure, you try to drive that number down. Your PSA is not something that we try to augment. So although debated, we don't use these medications and think of them as protective. In fact, if I saw a gentleman in the office, his PSA was 3, in a generic scenario, we would consider that a normal PSA. However, if we got a good history and identified that he was on one of these medications, that PSA is actually 6. We would consider it 6, which is over a generic cutoff of 4, and starts a workup, would identify that individual as requiring a potential discussion for next steps. So identifying that is very important, okay? So the screening of prostate cancer, how do we do this? If you Google this, there are a lot of different governing bodies that have opinions in this forum. But just to keep it simple, I'm a urologist, so we will present the American Urology Association guidelines that were published in 2023. So for men under the age of 40, we don't recommend screening. The risk of prostate cancer here is less than 0.1%. So we typically recommend against screening. But as men get into their 40s, it is okay for really any guy to start their screening of prostate cancer. But we want to identify a certain subset of men that would benefit from earlier screening. And who are they? I mean, we've touched on them already a bit. So it's going to be men with black ancestry for those same reasons, earlier, more aggressive, more likely to get. Individuals with family histories of prostate cancer or similar, certain GYN malignancies, or individuals that have known germline mutations, right? They often will go hand in hand, a family history of malignancy, and that's maybe a sibling of somebody who has other family members with cancer, and they've been identified as having, you may be aware of, let's say, BRCA1 or 2, the BRCA genes, that can put you at higher risk of prostate cancer. So just having that knowledge, we would want to screen you at an earlier age. As you get into your 50s, the AUA, the American Urology Association, our guidelines recommend screening your PSA every 2 to 4 years. Admittedly, we do it probably about every year. And getting a guy into the doctor's office, I think, is hard enough. So what we want to do is make sure while we're there, we're staying on some predictable and on a cadence, right? So we typically will check it every year, but guidelines, I should be, saying this is every 2 to 4 years. But part of that process is a shared decision-making. Everybody is going to treat their health different, right? So my goal as a urologist is to individualize your health plan by what your goals are. So we may look at your age, what your PSA has been in the past, what your life expectancy is, your general health. So we like to come to a decision of how often we are going to screen it with these guidelines in mind. Now, as you get into your 70s, guidelines would say that we start to have more of a discerning eye in the individuals that we should be screening PSA. And why is that? So, the average life expectancy of men in the United States is 78, yes. And unfortunately, COVID did dip those numbers. But if we remove that in the timeline, average life expectancy is about 78. And in some of the healthiest countries in the world, 81, 82. So I don't want to say I'm committing anybody to the grave here anytime soon, but it is something that we've recognized that the surveillance and screening of prostate cancer may not actually provide benefit. We may be chasing the workup. We may be finding prostate cancer, treating it, introducing risk and or side effects of treatment to cure something that, had we never found it, would never have even hurt that individual. So that's where the shared decision-making comes in, okay? When and how. We all know an individual who's 72 who's still running marathons and is super healthy, and we've met a 65-year-old who has poorly controlled diabetes or high blood pressure and has had 3 heart attacks. We view those individuals different, and we want ultimately to keep you safe. So what are the thresholds? What do we consider normal and abnormal? So for men in their 40s, a cutoff would be 2.5. As you get into your 50s, 3.5. A generic average number is 4 for men in their 50s or really 60s and above. But, by guidelines, it would say 4.5 for men in their 60s. And then you would see in the 70s, for those reasons that we just discussed, we moved that cutoff a little higher to 6.5. Okay, but again, shared decision-making, taking your overall health into context. There are other additive or adjunct tests that you can perform. So you have a mildly elevated PSA, you're fearful of a biopsy, maybe proceeding with a biopsy isn't necessarily in line with your goals of care, and you're trying to decide, what do I do with this information? We can order some of these other proprietary tests, 4K scores, exosome DXs, urinary tests, to try and help gather information. We can test some different proteins or different endpoints in these tests. You get plugged into this company's algorithm, and it says that your risk is low, elevated, intermediate, and it may provide some more information to break a tie in your mind with, yes, I just want to proceed with a biopsy, or I'd like to continue to observe for now, okay? But typically, the next step that we move on to is an MRI of the prostate, okay? And this has really grown in utilization in the last, let's say, about 8 to 9 years, specific for prostate cancer. And why is that? So this is a busy slide, and it's probably for a crowd that is more medical. But the point is that we have seen the magnet, right? So the M in MRI stands for magnetic resonance imaging. So your prostate, we've all talked about this multiple times tonight, is a dense organ, although small, deep in your belly, surrounded by bone. So until we've been able to develop a strong enough magnet to tease out some of the detail in it, it wasn't really utilized. But now with a 3 Tesla magnet, we can tease out some of the information within the prostate. We utilize gadolinium, which is just a contrast, an intravenous contrast, which helps us see detail within the prostate. If you're somebody who's been allergic to CT contrast, CAT scan contrast, iodine, shellfish, there's no cross-reactivity with MRI contrast, so you can feel comfortable proceeding with this. Okay, sometimes that gets lost in conversation, but you cannot proceed with an MRI if you have metal, pacemakers, bullet fragments, etc., right? Orthopedic metal is typically okay. Knowing this information isn't necessarily important. It's just knowing the fact that there are different ways that we're able to look at the image, different computer algorithms to look at the same gland to risk stratify areas of interest. Okay, areas or regions of interest is really what we're looking for. Okay, and I have this conversation with patients constantly because I'm constantly ordering MRIs of the prostate. There is a grading scale that will show up or not show up on your interpretation, on your imaging report. So if there are no areas of interest, you may notice a PIRADS 1, which is the grading scale, 1 or 2, okay? But you may, unfortunately or fortunately, see information that says there's a PIRADS 3, 4, or 5, and then an accompanying sentence that says prostate cancer is equivocal or likely or highly likely to be present. This test is not diagnostic, okay? This test doesn't tell you, yes, I have prostate cancer, or no, I don't have prostate cancer. It just tells us how to do a biopsy. These regions of interest are simply just that. There's a grading scale, but it just tells us if we do a biopsy, we're gonna do it our standard way and add in these areas that we've seen in the MRI. Okay, so patients ask me all the time, you know, if my MRI is negative, does that mean I don't have cancer? No, there is a chance you have cancer. It's good, there is a level of reassurance, but there have been studies that quote up to 20% of negative MRIs can harbor clinically significant prostate cancer, a level of prostate cancer that we care much about. But what if your MRI has a lesion of interest? Again, to hammer the point home, it doesn't mean that you have prostate cancer. It just means that that area would be added into how we do a biopsy. Okay? So it's really important when you get this information, take a deep breath when you get the report and talk to your urologist. Okay, so you've decided in conversation with your urologist, you want to move on to a prostate biopsy. All right, so if you've talked to a lot of friends, more traditionally, I'd say the last 20, 30 years, we were performing office-based procedures to do a transrectal prostate biopsy. Typically in the office, on your side, legs pulled up to your chest, an ultrasound probe is introduced into your rectum, and after some local anesthesia, we poke the prostate through the rectal wall. Okay, so with this, you can imagine the concerns, most notably infection, around poking through the poop tube. Right? You don't want to introduce fecal material into the body. But it was a very reliable way to perform a biopsy. So how do we go about lowering that risk? We're doing rectal swab cultures, giving you antibiotics before, during, and after to try and keep that infection risk low. We kept asking ourselves, is there another way that we can perform this biopsy? However, when you poke the thing, when you poke the gland that you urinate through or produces your ejaculate, you're going to see blood. Right? But that's something that will resolve on its own in a few days after the procedure. It's really the infection that we mind. And it's stated up to 1 to 3% of the time transrectal. What I've transitioned my practice completely to are transperineal biopsies. So similar in that we're biopsying the prostate, but different in how the needle is passed. Okay? It can be done in the office. I've done them in the office with men laying on their backs with their legs up in the air. No man loves that. So typically what we do is take these men to an ambulatory surgery center, the operating room, give you a little medicine similar to a colonoscopy, and keep you comfortable, and remove some of the anxiety around it. But what it is the needle actually passes through the skin, behind the scrotum, above the anus. So we can clean that area, okay? The thought is that infection risk is lower if you do this. I was part of a study when I was at Cornell, with a multi-institutional study where we found there was no difference in infection between transperineal and transrectal. However, my point with that is they are different. You're comparing apples to oranges. We give you a bunch of antibiotics and check your rectum, and with an eye towards antibiotic stewardship, we're admittedly doing a lot more to keep your risk lower transrectal versus transperineal. You technically could just walk in and do it. We do cover you with antibiotics. But the point is that infection risk is probably lower without sacrificing cancer detection, and it actually gives us a different angle. So we may be able to sample the front of the prostate, the anterior aspect if need be, in order to sample certain areas of interest seen on the MRI. So how does the MRI play a role in your biopsy? It's obviously obtained days, weeks, months prior. We're in the operating room, we're not in an MRI suite. Your MRI is uploaded onto a computer software. So the ultrasound probe that's introduced into the rectum at that time is tracked in space. So as we move the ultrasound probe left, right, up, down, or base and apex of the prostate, so does your MRI move on the computer software program, literally a fusion. So we're finding those areas of interest utilizing ultrasound fusing to your MRI. And we're able to sample those specific areas graded on the previously mentioned scale to identify if there is or isn't something there, okay? So, unfortunately, you're diagnosed with prostate cancer. Okay, what are we doing now at this point? The risk stratification, every patient asks me, what stage am I? You know, am I stage 1, stage 2? A lot of cancers are treated based on your stage, right? Breast cancer specifically is a stage-driven management. Prostate cancer does have stages, but it doesn't really drive management. We utilize the 3 variables to help classify an individual into risk groups, low, intermediate, and high risk groups. Your digital rectal exam, trying to understand if cancer feels like it's hanging off the prostate, locally advanced. What the total value is of your PSA, less than 10, 10 to 20, over 20, gives us some indication of possible severity. And then the pathology. Okay, how does it look under a microscope? What does the histology look like? So, not to say too much about pathology because it is confusing. If you or you know someone who's been diagnosed with prostate cancer, they start talking about your Gleason score and it goes over your head, right? Donald Gleason was a pathologist. He worked at a VA hospital in Minnesota, and he came up with literally pattern recognition. This is cancer, this is not cancer. If it is cancer, what does it look like? Matching it up to a chart. And again, it gets a scoring system. And that's where you see that math problem. 3 plus 3, 3, 4, 4, 3, etc. But we utilize that information with your rectal exam and your PSA to put you into risk groups, okay? And our treatment recommendations are based on which risk group you're in. We can get more information. There's a quick word on genomic tests. Everything we've done to date is just how it looks. If someone's smiling in a picture, they're a happy person. But that might not necessarily be true. If they're frowning in a picture, they're sad. Also, it might not be true. If it looks bad, is it bad? So the genetic tests, for example, the Oncotype DX or Decipher specifically, will look at a number of genes, whether they're normal or abnormal. With that information, we can't know what to do with it. We plug it into the computer algorithm and compare you to other men that may have those same abnormal genes. And then we know how they did, that cohort of men, how they did long-term, and maybe give you some information based on your genetics, how you may perform long-term. Can we watch it? Should we intervene earlier than we would think based on some of that information? So a treatment strategy, we have active surveillance for the low-risk group. We used to just treat every man who was diagnosed with prostate cancer, and we found we were over-treating a large subset of men. With, supposed to say 20 years of follow-up, by now it's been over like 30 years of follow-up, we have seen a large cohort of men be able to avoid treatment, okay, by just actively monitoring their cancer. We'll talk about that in a little bit because there's some intricacies in making sure we understand if you're going to stay in that low-risk group. With men who graduate into intermediate risk, we may be able to still offer active surveillance to well-selected men. We can offer focal therapy, which we'll talk about, but that is an investigational new emerging technology to treat well-selected men who have cancer in a spot, okay? Conventional treatment options, surgery and radiation, where we treat the whole prostate. And then in your high-risk group, a bit easier, more straightforward in the sense that we got to get in there, we have to treat it, and we're going to use conventional options, surgery or radiation. Watchful waiting, a quick word on that. Active surveillance, watchful waiting are not the same. Watchful waiting would be for a man who was diagnosed with prostate cancer through a TURP, through a procedure to help them urinate, or in some other form, and treating it may not provide them benefit, right? They're sicker, they're older, it's not within their goals of care. Watchful waiting, we just say, let's just see if we feel it. Let's see if it causes a problem, okay? Because getting in there and treating it might not provide them benefit. But it shouldn't be confused with active surveillance where you're actively watching to see if it's gonna get worse. So, staging information. Now, we've put you into risk groups, low, intermediate, and high. The next thing we want to know is it localized or has it spread around the body? So, more conventional imaging. So we say older, but really it's just been about 6 years. We were utilizing CAT scan and bone scan to help us understand if prostate cancer had spread outside of the prostate. So CAT scan, X-ray technology, everybody in here has probably had a CAT scan, right? Just looks for abnormalities. With the help of contrast, intravenous contrast, it gives us detail to tell us if lymph nodes are bigger or if there's any areas that look different, odd in bone, okay? So it's simply just looking for large lymph nodes, nothing necessarily specific about it, just enlarged lymph nodes and areas of abnormality within bone. Bone scans can help us as well. It's a nuclear medicine test using a different intravenous tracer to look for areas in bone that also look abnormal. So you start to put these two pieces together and it's not very specific. right? It's not as good as what we've seen utilized in other cancers, PET scans, okay? PET is an acronym for positron emission tomography. You've probably known a lot of individuals who had PET scans for their various cancers. We weren't able to use it for prostate cancer, but what it is a CAT scan where the intravenous contrast is given, and very simply, oversimplifying it, it floats around and tries to stick to the cancer. And if it does, that tracer, where it is, will glow. And if we scan you, we don't want to, but what we could see is glowing outside of the area of interest. So if you have glowing in your lymph nodes, areas of avidity in your bone, we start to be concerned that the cancer has spread. So this scan that we utilize is prostate-specific membrane antigen PET scan, a PSMA PET scan, using prostate-specific tracers. Okay, it's much more sensitive and much more specific for prostate cancer. It's not 100% accurate, but it is much better when compared to conventional imaging for us to understand if prostate cancer is localized or spread. Now, the treatment of prostate cancer. For these men in the low risk group, and I want to make sure I read this specifically, because the AUA definition of what active surveillance is the deferred treatment. So maybe not necessarily treating you now, we can treat you later. It's not so bad right now, so we can defer treatment so as to avoid side effects with disease monitoring with the intention to treat for disease progression or patient preference. So it's for those patients in the low risk group. We've seen through that 20 years of follow-up that a lot of those men will not see a significant progression of their cancer, and had we treated them, we would have cured them, sure, probably wouldn't have hurt them, and all we did was introduce the side effects of the various treatment options that they chose, okay? So an example of an active surveillance protocol is your initial biopsy, another biopsy 1 year later to confirm, literally called your confirmatory biopsy, to make sure the first one sampled the prostate correctly. And if those are concordant, then you are officially on active surveillance. We would then plan a repeat biopsy in 3 years. We would check your PSA every 6 months intervening with intervening MRI and rectal exams. If any of those details missed, we can repeat another biopsy to look inside to see. It's a preferred treatment for men in low risk. Focal therapy. These are men that have graduated to having intermediate risk prostate cancer for well-selected men. If you go on the AUA website, NCCN guidelines, etc., and try and follow the algorithm, the little flow chart, you will not find focal therapy. It's not part of our treatment recommendations. It's new, more broadly used in the United States for the last about 6 years, more broadly used in Europe, longer follow-up in Europe, but not that 20 years of follow-up you want to see. So it is investigational for men with cancer that exists in just a spot. Focal therapy is an umbrella term. You can use different energy sources to treat a spot within the prostate. So we'll talk about those sources, but what you want to do is you sacrifice some cancer control because you're not treating the whole gland, just that spot, but you are reducing side effects, effects to urination and effects to erectile function, which are higher when you're treating the entire prostate. Okay? Focal therapy, you have your HIFU, IRE, and cryotherapy. Cryotherapy is simply just freezing an area of the prostate, used in certain specific and select instances. There's NanoKnife, or IRE, which introduces small electrical probes that passes electricity and ablates or destroys prostate cancer or prostate tissue in that region. Or what we have with Hartford Healthcare is HIFU, which is high-intensity focused ultrasound, and that literally is ultrasound turned up to target an area, heat, and ablate the tissue. FDA approved to ablate prostate tissue. We use that FDA approval to treat prostate tissue that ... has cancer in it, okay? But it's not FDA approved for the treatment of prostate cancer. So if you choose an option like that, you have to be well informed and understand that this is outside of necessarily guideline management, but you're doing it because you want to try to avoid some of the more traditional side effects. This is what the platform looks like, okay? It's an ambulatory procedure, okay? This is HIFU. It's an ambulatory procedure performed in the operating room under general anesthesia. We introduce the ultrasound probe into the rectum, okay? And what I'm going to attempt to do, I'd like to skip that one, is show this slide. So we introduce the ultrasound probe and scan and map your prostate. Okay, we can see the boundaries of it. We know from your biopsy where the prostate cancer exists with the addition of your MRI, and we target that area outlined here in blue, where we deliver high-intensity focused ultrasound to buzz, zap, ablate, think of a word, to treat that area of the prostate where the cancer exists. Okay, and you are treating a focal spot, so you're not treating as many nerves, right? The nerves for erections sit alongside or behind the prostate, literally against the prostate, cradling the prostate. So if you're treating the left side, you're totally avoiding affecting any nerves on the right with an eye towards maintaining or keeping erectile dysfunction post-op. Now, you're not affecting the prostate globally, so you may see less effects, and we do see this, less effects on urinary function after focal therapy. Radiation therapy, okay? External beam radiation. People probably know somebody personally who had the seeds. You know, everyone always asks, can I get the seeds? We don't often use brachytherapy, the seeds anymore. It was very well used. They're literally seeds that are radioactive placed into the prostate and emitted radiation over time. But it was used for low-risk cancer. Those guys did well. You know them. They did well. They did well because they do well if we do nothing. And then CyberKnife. CyberKnife is radiation. So CyberKnife is radiation. CyberKnife is radiation. The reason why I say it like that is because I think the marketing is very good, but I think it is it can be misleading. There's nothing necessarily cyber about it. There are no knives. It is radiation. When you need radiation, you need this much. A round number, 80 gray. It's a measurement of radiation. You either get small chunks, right, every weekday for 6 weeks, 30 treatments, or 5 big chunks, right, big doses of radiation. Which is better? That's a conversation for you to have with your radiation oncologist, right? But understanding what they are is the first step in choosing what to do, okay? Now, what is better, radiation or surgery? From the perspective of cancer control, doc, I want to cure my cancer. Which is better, surgery or radiation? Nobody should, and nobody could, look you in the face and tell you that surgery is better than radiation or radiation is better than surgery. They're fundamentally different in what happens, but with respect to cancer control, they are the same. Okay, so the side effects, going through radiation is easy. Just lay there, right? I'm oversimplifying it, of course, but you just lay there and the radiation goes to your prostate. The side effects typically show up years later, 2, 4, 6, 8, even 10 years. If you're very young, you're diagnosed at 50, God forbid, and you're cured, you may have to live with the side effects of radiation 20, 30 years later if you live to 78, 80 years old. So the rare, but more common when years removed, secondary cancers can form as a result of radiation exposure. But typical effects to how you urinate, irritation of the bladder and rectum, blood in your urine, these are the more common side effects that show up in that 6, 8, 10 year later window. And a quick comment on erectile function. Again, the nerves to the penis are alongside the prostate itself. So with time, right, radiation nothing happens right there. Fragments, breaks the DNA, and the prostate turns into scar with time. Right, surgery cuts, it's gone, but radiation takes time. So the side effects to the nerves will take time to show up later, okay? So 2 years after surgery or radiation, those lines, your erectile function is typically the same regardless of option that you pick. Surgery, okay? The surgical removal of the prostate, the seminal vesicles, the bags on the back side, and the lymph nodes, the first step where prostate cancer likes to spread. We used to do it open, small cut below your belly button, put our hands in that small space and try to pull out this walnut. It was miserable. Laparoscopic surgery, which people are quite familiar with, the small instruments introduced into the belly, and a surgeon would contort themselves in some fashion in order to hold the sticks, the instruments, small keyhole openings in the belly, but was cumbersome. And you didn't have the dexterity of these sticks, of these laparoscopic instruments. So we have seen, and it's totally replaced prostate surgery now, is robotic-assisted laparoscopic prostatectomy or radical prostatectomy. So the robot holds those instruments. The surgeon, myself, would control the robot. There's no auto park. right? There's no autonomy where we just sit back and, enjoy some time while the robot's doing the surgery. There is none of those moments. Every movement is controlled by this surgeon. So it's robotic-assisted laparoscopic surgery. And so the advantages of this, a 3D camera, smaller incisions, low blood loss, right? Because it's laparoscopic surgery. We're filling the belly with gas, which pushes on small blood vessels that may ooze otherwise. It provides strong cancer control and is the preferred surgical method that we utilize. The surgery itself, we're in the operating room 3-ish hours. Surgery is typically a little less than 3 hours. You wake up with a catheter in your penis, and you stay one night in the hospital, okay? Typically, you go home the next day with your catheter, and we take that catheter out 1 week later. The side effects, in addition to your general surgery side effects, bleeding, infection, and damage to other things, we want to know that you are strong enough to tolerate a challenge to your body, surgical procedure. But in general, if you talk about this, the procedure specifics, it is urinary leakage. So your prostate, we talked about how much trouble it causes to urinate. Well, it helps hold urine in your body, in a way. And the sphincter that sits right below the prostate pinches the tube that you urinate out of it closed. So when we remove the prostate, that sphincter, that muscle that pinches your urethra closed, is alone. It needs to recover, take 6 to 8 weeks, and then it needs to get stronger to do the job alone. So that takes time, and as it takes time, you leak. 6 months after surgery, over 90% of men will be dry, but it's 6 months, right? It can be sooner, but just law of averages, defined as one thin pad in their underwear. Okay, so to come back to the risk stratification, depending on which group you're in, low, intermediate, and high, we tailor our recommendations based on those risk groups. Okay, so some quick commentary here at the end about the role of testosterone. So, as Dr. Altbaum said, prostate, testosterone itself can be thought of as food for the prostate or food for prostate cancer. Now, there's maybe some men in this room that are on testosterone replacement. You have low testosterone, you had an educated conversation with your doctor, and you started testosterone. And you're worried, am I going to get prostate cancer? Supplemental testosterone does not cause prostate cancer. It will not cause it. There is a discussion that we have at our national meetings that it may unearth or fuel prostate cancer that already exists there. Right? Like, we have that conversation all the time. The reality is it's probably not entirely true because we're not making you Superman when we give you testosterone. We're just giving you enough to bring you into the normal level. So your risk of prostate cancer would, mirror that of men with that similar normal level of testosterone, right? So if that's true, right, if we give you testosterone and it may grow prostate cancer, we know that if we take it away, it can control prostate cancer. If we take the food away, the prostate cancer may not grow. And we use that in 2 situations, okay? So we talked about radiation. Nothing happens. Of course, something's happening, but it takes time. That fragment of DNA, turning it into scar, we want to sometimes, for higher risk cancers, hold it in place. So we take the food away for 6 months, for 2 years, to let the cancer lie in wait, while the radiation effects treat the prostate, okay? Or if unfortunately prostate cancer has spread around the body, we cannot cure that individual. We just want to control it, cut off the food supply, and have you live a long, happy life and pass away from something else, right? So that's kind of the goal. What are some of these medicines? Okay, most common medicine men, have probably heard of or know somebody on, Lupron, okay, which is an LHRH agonist, works above the pituitary gland. We give this, and after a spike, it will castrate a man, okay? Other medicines like Degaralex, these LHRH antagonists, castrate you quicker, but ultimately just moving your prostate down less than 50 or close to 0. There's other medicines that we utilize in a graduated form, okay, androgen receptor blockers, your enzolutamides, apalutamide, etc., which just further lower testosterone. Prostate cancer will try to find a way to grow after some time. We take the testosterone away with Lupron, it's going to try to want to grow, so we just keep introducing new medicines as a graduated approach. Then also testosterone is made in the testicles, and it can be made in the adrenal gland, and we can shut off the production of testosterone in the adrenal gland with the use of abiraterone, which shuts off the synthesis of prostate cancer. Okay, so in men that have metastatic prostate cancer, we give you medicine, take the testosterone away, prostate cancer sits quietly in the background. It will try to find with time way to grow, and when it does, we can see a rising PSA despite having no testosterone in your body. and what we refer to that as castrate-resistant prostate cancer, and we move along the algorithm giving you new medicines. But what is this sensation? What is this experience? What are men going through? You are essentially going through what we affectionately call menopause. Right? Women, when they go through menopause, they lose their estrogen. So hot flashes, mood swings, weight changes, bone density issues, etc. So that's the female struggle. We introduce this to men in these settings when we take their testosterone away. Hot flashes, we monitor bone density. There can be issues with metabolic syndromes and so forth when men are on these medicines. So it's important to get this guided by your medical oncology colleagues. Okay, so in summary, what did we talk about? So prostate cancer is common, the #1 diagnosed cancer in men, right? 3rd leading cause of cancer death, which highlights the importance of screening. You want to find it early so you have the ability to be offered the full breadth of treatment options that we talked about before, and then be able to guide it based on what your goals of care are and what you want. We talked a little bit about those adjunct tests. You're waffling, can't decide, biopsy yes, biopsy no. I wish I had a little bit more information. There are other blood or urinary tests that can help provide more information. Will not diagnose you, but can help give you some more clarity in how you want to proceed. A biopsy is really the only way to say you do or you don't. Everything else is information gathering. The MRI prostate, it is my opinion, and many others' opinion, that an MRI should be performed, if possible, short of metal in your body, etc., should be performed before your biopsy and in order to guide how a biopsy is performed, okay? So afterwards, we say we looked under every stone, we looked in every area, and this is your diagnosis. I couldn't find it, but if I did find it, I feel like you're accurately staged, okay? We talked about genomic testing, looking at the risk factors of gene aberrations. We talked about the utilization of PSMA PET scans, a newer CAT scan-based PET imaging to tell us if prostate cancer has spread or exists only within the prostate. Focal therapy, again, highlighting that this is investigational for well-selected men, and it doesn't have the long-term follow-up that a lot of the more conventional treatment options have, but it is growing in popularity in the United States and worldwide. We talked about radiation. We talked about surgery, and then we touched a little bit on the role of androgen deprivation in multiple settings, radiation and metastatic. Okay, so with that, I want to thank you guys for having me.
Let's go sit.
Yeah.
So could we open up the Q&A? Very good. So if you have any questions, please go to the microphone and ask. We only ask that they be relatively general questions, not your PSA was 3.2 last week and it's 3.6 this week. Is yours live? Yeah.
It might be. Yep. Yeah.
Yes, I'm still a little confused as to how proactive a person should be. I mean, should we just rely on our annual physical and the recommendations of the doctor there, or should we be more proactive?
That's a great question, because, so the question I'm sure everyone heard is, how proactive should you be? I always encourage all of my patients to be an advocate for themselves, right? I mean, ultimately, the responsibility stops with each of us. We take an oath to do no harm. We have and feel, I do, and I know Dr. Altbaum does, right? To feel a strong responsibility for the health of our patients. But we want to make sure that we're doing things that are in alignment with your goals of care, but some of that is likely to be an assumption at times. So when you get to the fringe, early screening or late screening, I think it's important to be educated in these arenas in order to be an advocate for what you do or don't want, so you're not just relying on an assumption.
I do want to say the United States Task Force has a different recommendation for screening from the American Urological Association. I tend to actually like the American Neurological Association, because the United States Task Force says that you should do it collaboratively, which is fine, and you should discuss all the different positives and negatives and the benefits and the downsides, and then it should be the patient's decision with you. And I've tried doing that when it first came out. You spend 15 minutes giving them statistics, explaining it to them, but inevitably they turn and say, I came to you to get your advice. I mean, this is something, if the urologist and the internist can't come up with an explanation, how can we expect the patient in 15 minutes? And as a general rule, I still think information is power. I think the American Urologic Association of getting a PSA, not annually, you can certainly get it annually, but an annual, the prostate doesn't follow the earth going around the sun once a year. That's the way we tell time. That's not biological. It's perfectly reasonable if you have a normal PSA in 2023 to wait till 2025 and see where it goes. And I think so 2 to 4 years is a reasonable screen. I think the other task force approach of basically leaving it up to the patient, again, this is totally, I think it's unfair to the patient. And I like the idea of being somewhat proactive.
Thank you, doctors, and thank you, almost Dr. Wilk. So I'll be 80 in January, and a couple of years ago, my urologist broke up with me. He said, I don't want to see you again. And I'm not clear, I know you sort of touched on it, but I'm not clear, why wouldn't I want to know that I have prostate cancer now?
Yeah. So I don't know about the breaking up, so I'm sorry that you had to experience that. So I tread lightly.
It's hard to do.
Yeah, yeah. But you do, that is, among anything, it's a sensitive conversation, right, for that reason. Why don't we want to know that I have cancer? So we know from some old studies that men in their 80s, this is years ago, decades ago, that died from other causes when we looked at cadavers and dissected their prostates. And over 50% of them had prostate cancer. They didn't know, right? They died from other causes. They didn't die from prostate cancer. And we do know that in a lot of settings, that prostate cancer is slow growing. So we do reach an inflection point where the prostate cancer could be there, but by the time it ever grew and hurt you in some fashion, you felt it or could cause the end of your life, you may be, unfortunately or fortunately, no longer with us or whoever the situation is. The point is, if we were to aggressively jump in, right, we could certainly change your quality of life, curing something that wouldn't have hurt you, but giving you a host of side effects, which you've worked very hard to stay healthy, to be alive, and to get to this, point in your life. And we have robbed you of that by changing how you urinate, which some men do 8 times a day. So, it's something that we want to, it's important, because ultimately, we said before, you're a driver, an advocate for your own health. We want to make sure it's in alignment. All we can do is necessarily offer you some information with how to proceed, but we want to, provide a little contrast to, what may be going on and what could benefit you or what could not benefit you.
Thank you.
Thank you, doctors. I am deep into prostate cancer. I was diagnosed about 12 to 15 years ago. Started out with a radical prostatectomy, moved on to 3 rounds of radiation. It is now metastasized to my body. I have cancer in my liver. I have cancer in my lungs. And basically, just a few weeks ago, I was given 24 to 50 months. I can't emphasize enough early screening. Keep on that PSA. My PSA right now is 12. And basically, I'm 81 years old. My urologist, Dr. Burney, said, most men die with prostate cancer, not from it. And I think that's true from your statements too. But I gotta say, early screening, stay on top. Thank you.
So I just want to thank you for sharing your story, and I want to wish you luck, because I know that's very hard. And you being an advocate's a real hero to other people to make known that how it can end up going. So I'm sorry you're going through that, and I pray for you.
My question is about someone that has a very low PSA, 0.01, but has metastasized prostate cancer, had the robotic surgery 6 years ago. So in addition to the testosterone depletion, my question for you is, what is being tested out there? What's new in the bag of tricks? What's new to the next round of defeating or at least slowing down this disease state having metastases? Not quite like this gentleman, but...
Yeah. Yeah, so it's a great question. So a lot of it, we talked a little bit, because you're asking, I think, about a metastatic setting. So what's being offered there? In the localized setting, we talked about the high-intensity focus ultrasound. So that's kind of the more emerging stuff in the local setting. In the metastatic setting, there's constantly investigations. So we didn't talk a lot about immunotherapy options that are medicines that you'll see a lot of commercials on, utilized in a lot of other avenues. We do use chemotherapy, right? When people are diagnosed with cancer, everyone asks about chemotherapy. It's not something, based on what we talked about here, typically used in the treatment of prostate cancer, except for a setting of men that have metastatic prostate cancer can benefit from the inclusion of chemotherapy. As far as emerging technologies, I can't comment a lot on it, but there are technologies where we give tracers that float through the blood, essentially, to oversimplify it, that can bind to prostate cancer and tries to treat it, essentially, where it is in the body. Newer, attractive, but not able to really comment and not something that's widely used. So it's just really challenging for prostate cancer or for any cancer to treat it once it metastasizes, right? Because then you're just chasing.
So is one of the markers on a metastasized circumstance with prostate cancer, in my case, it's just with a few lymph nodes, just the PSA? Is that the only marker that's being used?
Yeah, it's PSA, as Dr. Altbaum said, when you look at how PSA is used, it gets a bad rap in the early stages, in the over-treatment, the over-diagnosis of prostate cancer. However, we should recognize that it is somewhat perfect in the setting of post-treatment, in the sense that it gives us the ability, and specifically after surgery, if you don't have a prostate, you should not have any PSA, assuming the cancer is gone. So if we can detect PSA, something is still there. And that conversation can tangentially get away when you talk about how long since your surgery, et cetera, what the pathology was, and so forth. But it is a marker for prostate cancer tissue or prostate cancer itself being present in the body. Right. So it's very good for our ability to, if we see smoke, there probably is an ember.
But nothing's really changed. That's the marker.
That is the marker. That is the marker because it has been in the treatment setting very reliable.
Thank you very much.
There are some treatments for people. I mean, unfortunately, the goal of all those treatments on testosterone is to get it to below a level of 50, and that's basically a castration level. And then, because testosterone can be made from other organs, as John mentioned, like the adrenal gland, we have medications that will turn those off. But when everything else fails, there are still some treatments. There's a drug called docetaxel that's been used for years, often in combination with androgen deprivation therapy. There's another drug which is related. I think it's called carbotaxol. I personally have never used it, but the medical oncologists use it. If people have specific mets to their bone, there's a radium-22. It's a radioactive radium that goes to the bone and can kill it. There's even that prostate-specific membrane antigen that's been used for scanning people that knew better than the CAT scan, than the bone scan. They can actually link that to radioactive material, and it'll go where the prostate is. And there's a very interesting thing, but it's only specifically, I think, used in people with the BRCA mutation, because some men do have BRCA mutations. And actually, men who have metastatic prostate cancer that's castrate resistant, meaning androgen resistant, actually have about a 15% incidence of BRCA gene. And there's actually a group of chemicals called PARPs, polyribose. I call them PARPs.
They're PARP
but
inhibitors.
They actually have also been used effectively to slow down the growth. None of these cure. But they have been shown to treat metastatic cancer that is androgen deprivation resistant.
I just would say when you get to these areas, it's important to get to high volume locations, academic institutions where clinical trials are open, or individuals who aren't just medical oncologists, but are medical oncologists with a focus on urologic malignancy, or even more specifically in prostate cancer. It's very important when you're talking about chemotherapies, PARP inhibitors, and any of the ionizing treatments.
Doctors, first of all, thank you for sharing your expertise with us. We really appreciate it. In addition to the PSA test, I have very recently come across, there's a test that has been developed in England called the PSE test, which is a prostate screening epigenetic test. It's a blood test. And what it is used, it detects 5 markers, epigenetic markers. And if these epigenetic markers have if you get a hit on those, there's, I think, like a 96% accuracy on the fact that this individual has prostate cancer. That's in England. I don't know if that test is available in the States. In England, it's like 750 pounds, not inexpensive. In the United States, Dr. Altman mentioned to me, because I mentioned this to him last Thursday, there is a test in the States, which I think may be about a year old. It's called Prostate, P-R-O-S-T-E-S-T. I'm assuming it tests the same thing. It has a slightly less accuracy, maybe 93 to 94% accuracy. Can you talk a little bit about that and the benefit of using these tests, assuming they ever get covered by insurance, in conjunction with the PSA test, with the idea of it could possibly eliminate the necessity of doing an MRI and a biopsy when these are not needed? Can you possibly talk to this?
So that's it. You said it. It's perfect. Right at the end there, that was perfect. There are a lot of tests. There are a lot of different adjunct tests, urinary biomarkers, hematologic or blood biomarkers that use their proprietary algorithm, their software, et cetera, looking at proteins and so forth in order to provide risk stratification for the purposes of breaking a tie. Right? So there's a lot of guys who will come in, their PSA is 20, I'm concerned, and we're talking about these tests. That's an exercise in spending your money, because it's very obvious that your PSA is at a point where we're significantly concerned. But in the setting that you're talking about, your PSA is 4.2 and you're younger, or you get into your 80s or 70s and you're trying to decide, Dr. Graham said the normal cutoff for a man according to AUA guidelines is 6.5. I had a couple cardiac things, mine's 6. I can't get an MRI because I have a pacemaker. What do I do? So we utilize these adjunct tests to try to break a tie, to give us some more information and risk stratification to say, you know what, we're gonna move in the direction of biopsy. It fits your goals of care, it fits our shared decision making, but we need a little bit more information to feel good about what we're doing is gonna be worthwhile. So yeah, we do use them. Everybody's practice of that is a little different, because you could just keep ordering them, spend a lot of money, but it may not. You're just, at a certain point, you're just gathering information.
Thank you kindly.
Absolutely.
Hi, thanks for everything, guys. This is a simpler question, I think, going back to Dr. Altbaum, with enlarged prostate. You're correct in that tamulosin does cause retrograde ejaculation, like you said. I disagree with you, and my urologist say, oh, it doesn't matter, it's the same thing. But anyway, if you lay off tamulosin for a while, I mean, that's a daily thing that you take. So is there some sort of period of time where it no longer has that side effect?
I don't know. Most people, if they do have tamsulosin side effects of retrograde ejaculation, it's really a sign that it's working. If you think about the mechanism, it's relaxing the smooth muscle, lowering the resistance out the bladder, but that's also lowering the resistance into the bladder. So it's not like if retrograde ejaculation decreases, the effectiveness of the tamsulosin is also decreasing. So it's unfortunately a known side effect. One drug which has gotten some press that it might be a little bit less, I really don't know the statistics, is a drug called uroxetrol. I don't know. But uroxetrol, when it was being marketed as less likely to cause retrograde ejaculation. Each of the products has a pro and a con. Some of the drugs actually are used for blood pressure lowering. Some of the drugs have less effect on blood pressure. But I think the two selective drugs, which are Rapaflo and Flomax, have actually a slightly greater incidence of retrograde ejaculation, but that's part of its effect.
If you were going to take Cialis, which of the two selective, you wouldn't take all three?
Actually,
together.
Cialis
You wouldn't
tends
take all
not to
three
cause
together.
retrograde ejaculation.
Right.
And it's interesting, Cialis, even though it theoretically works similarly to the alpha blockers, when you actually look at the urine flow, it doesn't dramatically affect the urine flow as much. And I have not seen retrograde ejaculation. Maybe John has, but I have not seen that with Cialis. And some people feel that Cialis might have effects on an anti-inflammatory effect or even affect the nerve sensation, which might also improve the symptoms of BPH. But it does not cause retrograde ejaculation.
But you probably wouldn't take Cialis in conjunction with the other two selective.
And the alpha blocker, well,
Yeah.
again, they both relax smooth muscle. Smooth muscle is in blood vessels. Blood vessels are in the body, and if you open up blood vessels, the blood pressure can get low. So they do tend to have a additive effect on lowering blood pressure. When you start an alpha blocker like Flomax, you usually start the first one, or usually there's only one dose, but you usually would start it at night. One, because you'll sleep through the lowering blood pressure effect, and there's also this evidence that there's a first drug effect where it tends to have its greatest effect on your blood pressure, the first dose. If you're going to use that with Cialis, you really have to go very low dose, very slowly. I would actually have the patient, I'd give them a home blood pressure monitoring machine, and I'd make sure that they don't get too low. Are they used together? Yes, they are. But it's tricky.
Thank you.
Yes, thanks again to both of you. This is another one for Dr. Altman. Prostatic artery embolization is something I've been reading about under the heading of treatments for BPH. It seems to be relatively new. Can you talk about that a little bit?
It's available. It's painless. It has few side effects in terms of retrograde ejaculation. Has a higher incidence of failure rate. If I can get to my slide, hold on for one moment. Let's see if I can find it. This is too much to go through. But basically, it's not as popular, and it does have a higher incidence of failure. It's not coming up. So it hasn't caught up. I don't know if you've been using it.
It works in well-selected men. When you think about what it does, the vascular supply to the prostate is somewhat redundant. There's this neurovascular tissues, and you're trying to just kill the prostate, cut off the blood supply, and hope that it shrinks in the area you want, the middle. So it's tough. It's tough for it to really do exactly what you want. We talked about the alpha blockers or surgery, right? Alpha blockers targeting that middle part of the prostate, or surgery where we physically remove. When you think about scooping out the fruit of a melon, you're not working on the peel, you're taking out the middle. When you use prostate artery embolization, you're hoping to achieve that by selecting blood vessels and hoping for death of the blood vessels it feeds. It works sometimes. And it's often reserved for, but again, the drawbacks aren't necessarily, if it fails, then it kind of fails. But what I use it in my practice is for men that typically can't tolerate other more durable, more straightforward, tried and true. So guys who are on anticoagulation can't come off it, Eliquis, Xarelto, Coumadin, etc. guys that have big prostates and couldn't tolerate surgery because it's so big, you know, no medicine's going to touch it. So why not, right? But it's often, for a lot of urologists, not a first reach. And when you look at our guidelines and how to manage intervention, looking at the vocab, it's a little bit lower on the list. Not wrong to start with, I should say that. It's not wrong, but not preferred.
Is it true that it's relatively new and there's not as much background and research on it?
Right, so there's been a lot of actually more recent comparative studies looking at the effectiveness of it, but the retreatment rates have been a bit higher with prostate artery embolization. Newer, yes, more broadly utilized is probably it. It's been around for several years, but it's being more utilized by our interventional radiology colleagues to offer within the armamentarium of the treatment of BPH.
Thank you.
Hi, thank you. I'm on both tamsulosin and finasteride, and about 6 months ago, my doctor put me on, and I'm not sure if this is a generic name or a brand name, Gemtesa.
Yep.
Where does that fit into the overall list of options that you mentioned?
So Gemtesa, when you talk about, and Dr. Altbaum did a great job, there's bladder storage issues or bladder outlet obstruction, right? So the two medicines you're on, the finasteride tries to shrink the prostate, makes it smaller so the tube is more open, right? Then you're on an alpha blocker to pass the urine through, okay? The bladder has been working for years to push urine through that slowly. What it can develop are bad habits, storage issues. So even though it's open, your stream comes out great, your bladder has bad habits, potentially. So you have frequency and urgency. So once we know you empty, once we know you can get the urine out, then we as urologists feel more comfortable quieting your bladder down. If you started with that, giving the bladder a break, right? It's not a muscle relaxer, but if you just let your brain go there and you quiet the bladder down, you're not as fearful that it's already half full, and if you stopped any mechanism of squeezing, it's just gonna fill up. So if you open the door, and you still have frequency and urgency, those irritative symptoms that Dr. Altbaum talked about, you can take a medicine like Gemtesa, right, which is Virabegron. There's another medicine similar called Mirabegron, which works on a receptor on the bladder, these beta-3 agonists, right, which literally quiets the bladder down, right? Flight or fight. When you're in a fight, you're not peeing yourself. So you try to turn that stuff on so you're able to store urine. So it helps this symptom management. If you can get it out, now you want to treat the frequency. So often is recommended for men for frequency. Nighttime frequency, urinating at night. We're gonna have to do another lecture series to talk about nocturia, because that is, when you're only urinating frequently at night, we try these medicines, they don't work. Nighttime urination is unique, okay? It's mostly managed with behavior. Don't eat or drink for 2 to 3 hours before you go to bed. If you put it in, it's gonna come out. And then lastly, if you have sleep apnea, you need to use your machine. You need to use your CPAP. It's this weird thing with pulmonary hypertension, and it causes your heart to create a chemical, and it makes urine at night. So your urine production increases while you have sleep apnea. And you don't urinate frequently during the day, because you don't have awake apnea, you have sleep apnea. So when you're in sleep apnea, if you use your mask, your heart doesn't make that chemical and you don't make all that urine at night. Gemtesa can play a role in symptoms that happen regardless of day or night.
Thank you.
One comment I would make just about the bladder relaxants. There are two categories. One is an anticholinergic, which works by blocking a chemical called acetylcholine. Problem is acetylcholine controls contraction of the bladder, of the colon. It controls tears, it controls saliva. So unfortunately, and acetylcholine has a lot of effects on cognition in a positive way. When you block that, you not only block the bladder, you cause constipation, you may cause dry mouth, you may cause trouble with tears, you may even affect problems with cognition. That group of drugs, and they're very common, have many more side effects than the drugs that Dr. Graham mentioned. Mebitrix, these beta-3 agonists, they may raise blood pressure. That's a potential risk, not very great that I've seen, but they don't have those other side effects. So they're, I think, a much superior product. Yeah. And if anybody's taking the anticholinergics for their bladder, they should be aware to ask their physician, because in the older person, the risk of cognition and constipation just becomes much greater.
Yeah, we really try to avoid it in your 80s because it can cause delirium. So that's really something we try to avoid. So we would select mirabegron, virabegron, Gemtesa, or mirabetriq and avoid the anticholinergics in that age group for that reason.
Thank you again for a very, very informational evening. I'm going to be very quick. I've had a very difficult year from a cardiologic standpoint. And I have been on a drug called amiodarone for about 6 months. It's already created problems for me in different areas, and I'm about to have my 9th biopsy in about a month or so, such as the newer approach. What is your experience, if you have any, with amiodarone in terms of throwing numbers off and creating problems with the prostate?
So I can't necessarily say that it's consistently an issue. I do hear, these type of things, from patients where, certain medicines are thought to affect the PSA values. It's not something I reliably see. I would just leave it at that. The medicines that really affect the PSA value can be, or the 5-alpha reductase inhibitors, but it's not something that typically should affect your total PSA value.
Okay, I was concerned when you say that because I went from 12 to 41.
Right, so then, that's quite a jump. But
Yeah.
you would want to make sure, and I don't know that I could point to amiodarone, right? I think that would, ultimately, if I did, would be a diagnosis of exclusion in the sense that we've looked at everything else. I can't find cancer in you, God willing, and I don't know.
Thank you.
Again, thank you, doctors. I have 2 questions. I think they're both short. My father had prostate cancer, had it treated, died at 94 of something else. Sadly, that's all I know about the details. In terms of my risk situation, should I find out more about what he had and how severe it was?
It's a good question. I think ultimately, because it really guides screening. So once you're in and you're on a screening protocol, and just knowing your father had prostate cancer, it might help. It helps us when, we learn that an individual was diagnosed and treated with prostate cancer at 84 versus 54. But again, the details get lost. So let's say your father was treated at 54, but going back to what we talked about before, he may have had low-risk prostate cancer, and we wouldn't have treated it, but back in the day, we would have done it. So those details get lost. So, I don't know that it's necessarily worth the effort it might be to get those details, but just knowing that should at least keep you motivated to maintain a level of a cadence to, let's say, annual PSAs and digital rectal exams with your primary care doctor or a urologist, either one.
Okay, second question. Is a Gleason score of 4 plus 3 the same as 3 plus 4?
That's good.
Is a Gleason score of 4 plus 3 the same as 3 plus 4?
That's good.
Actually, no, they're not.
Yeah.
So what's the difference?
It sounds like they should be, doesn't it?
No.
Yeah.
The way the Gleason score is done, actually, I should defer this to John.
Well, no. The answer is no, but it's a great question, and I avoided it when we were talking because it's tough to explain. So when you see those numbers, the pattern that Donald Gleason came up with is a chart. This is cancer, and you match it up, and if it looks like cancer, it can look like pattern 3, pattern 4, or pattern 5. So you can imagine a situation where a pathologist looks through and says, okay, I see some 3, there's some 4, there's some 3 and 4. How it gets reported indicates volume. So if it's 3 plus 4, it means within that area, in that biopsy core, that one poke, they saw more pattern 3 than they saw pattern 4. And as that number increases from 3, 4 to 5, so does severity. So in an individual who has 3 plus 4 prostate cancer, still equals 7, it wouldn't be as concerning, although it still is, than an individual who was being driven by pattern 4, where on that biopsy core, they saw more pattern 4, more of the aggressive form, comparatively, than 3. So 4 plus 3 has more pattern 4, more of the aggressive, than pattern 3, conversely to the 3 plus 4.
Okay, so a little curveball. I've had 2 biopsies. One came back 3 plus 4. One came back 4 plus 3.
Right. Really good question. And Ultimately, it doesn't necessarily change your risk group as much. There's some subtleties in there that we would have to tease out, but how is that even possible? Think of your prostate and you have an area that cancer is in a spot. And you would love if you just were able to perfectly sample it. The needle goes through and you have a true representation of the volume of cancer in that spot. Unfortunately, that's not how the world works, at least not right now. So you could glance it, right? And you can glance it favorably or unfavorably, where you catch an area where you just caught more 4. And then you did 3, or vice versa. So there's situations where we have taken men's prostates out, and every time I take someone to the operating room, I always tell them we can find, the cancer can look better because we're able to see it all. It can be the same as what we thought, or God forbid, it can be worse, because now we're able to, it's not your templated biopsy, we're able to see all of it. So it's tough to really answer which it is. What we assume, though, and what drives our treatment is typically what's worse, unfortunately.
Thank you.
Yeah, absolutely.
Anyway, I think, wow, we thank you for all for staying. It's really, I really appreciate it. We both appreciate it. I hope you learned something. I hope you don't need to learn as much as you learned, but we are going to be continuing the medical series. We will come out, probably we will restart in 2026. So please look at the Westport Library Circular to know when and what topics. If you have any particular topics that you would like, because we have a list of subjects, but if you think they'd be more popular, more interesting, we are happy to address any suggestions as well. Again, thank you all for coming.